All right, I will kick us off now. I'm Liz Stewart. I'm Methods Core co-director for the Johns Hopkins ALACRITY Center for Health and Longevity in Mental Illness. This webinar now and recording that will be online is part of our Advanced Methods for Mental Health Services Research series. And so we have a set of talks that this is one part of. So same thing on this slide. Again, this is part of a series hosted by the Hopkins ALACRITY Center, where we try to highlight methods of relevance for mental health services research. More broadly, just as context for any of you new to ALACRITY and this world, this ALACRITY Center is a research practice translation center designed to address the wicked problem of premature mortality and medical comorbidity among people living with serious mental illness. The broader ALACRITY Center has these aims, which are again really around implementation strategies to implement and scale evidence-based interventions in community settings, enhancing community partnerships, building capacity, and then again, advanced methods for implementing and scaling evidence-based interventions. So this webinar today is part of the Methods Core in particular. Again, I'm Liz Stewart. I'm chair of the Department of Biostatistics at Johns Hopkins and co-director of the Methods Core with Beth McGinty. The Methods Core itself has a combination of innovative methodological development work, and then also things like this webinar series where we are trying to, again, sort of disseminate methods and help share information that really help researchers all around the country and world who are doing mental health services. So we will put this link in the chat, and it gives a link to the recordings that we have available already online. And we have this YouTube channel. So this recording will be on that YouTube channel probably in a few days. So I'm thrilled today to welcome Dr. John Jackson. Dr. Jackson is an associate professor in the Department of Epidemiology here at Hopkins with joint appointments in mental health and biostatistics. And you can see his title here. I don't have a long formal introduction for Dr. Jackson. He got his SCD at Harvard and really is, I think, one of the world experts in these topics. He really helped set out this framework of how to use causal decomposition analysis to really intervene to reduce mental health or disparities in general. And again, today we'll hear sort of and talk about relevance for mental health. So really looking forward to learning from Dr. Jackson. Again, I think we couldn't ask for a better person to be teaching us about this. We will aim for the seminar part to last about an hour. I will be monitoring the Q&A, and we welcome people to put questions in there. We might stop for sort of small questions along the way, but then we also will have time at the end for discussion. And I will say in this series, there's been really good discussion at the end where we can really use some of that time to dig into the relevance for work such as done with ALACRITY and mental health services. So I encourage your engagement. I look forward to the questions and comments. And with that, I will hand things over to Dr. Jackson.
It's an honor for me to present today. As I'll discuss in the talk, once upon a time, I did a postdoc at MGH in the Boston University School of Medicine, where I was housed in at least part-time in a clinic that was really dedicated to serving patients with schizophrenia. And so as I was launching this work, I was existing in this world. And so I was always thinking about these examples when thinking about disparities. So as Liz mentioned, I'm going to talk about a framework that I've termed causal decomposition analysis. And the motivation of the framework is really to help us identify high leverage points around which we could build interventions, or even you could think of it as even adapting existing interventions to reduce mental health disparities. And there's different ways we can think about mental health disparities. I do want to acknowledge the funding from the National Heart, Lung, and Blood Institute, which has been instrumental in helping to further build this framework. particularly to further develop methods and also help with its dissemination. And I must say that what I'm going to present here today does not necessarily represent the official views of the NIH. So I'm going to aim for a really high level talk today, opening up with some motivation, framing things around a specific stylized scientific question. Think about the assumptions we need, how do we estimate answers to this scientific question, and then walk through two applied examples, and then set the stage for the discussion. If what I have to present today interests you, there's a range of papers by my research group and also many others that you could read. This is probably this first paper here that I published in Epidemiology in 2021 really kind of set the stage for the methods that I'll talk about today and the perspectives today. So this is a great place to start. One of my star doctoral students, Michelle Jin, recently published a review of this framework in Current Epidemiology Reports that came out last year. That's also a great place to begin. And then in April next month, there will be a really high level a review paper that situates this framework within the broader context of causal inference within health disparities. I think that'll be a very accessible read that should come out next month in April. And then we have some working papers that are also highly relevant. So we'll work with Trang Nguyen and some trainees, Ting Xuan Chang and Esther Mech. We've really built some nice estimators for causal decomposition analysis, which is up on arXiv. And then finally, we can think about, I'm going to talk about a specific type of intervention today, but this falls within a much larger class of ways to intervene. And so there's a working paper that talks about this broader framework using notions of hypothetical trials that you might try to emulate. And that's also existing as a preprint in arXiv and is under review. So with that, I'd like to start with some motivation of why this is important. And again, as I alluded to earlier, it goes back to my days as a postdoc, where I was housed in a shop that really examined or was really treating persons with serious mental illness, particularly schizophrenia. And one of the things that struck me was learning that you could conceive of persons with serious mental illness as a population that faces disparities or excess morbidity and mortality relative to the general population. What I learned really surprised me was that there was a 2 to 3-fold higher mortality in this population compared to the general population, with significantly reduced life expectancy. And also that this gap in mortality and life expectancy is actually worsened over time, despite concurrent advances in medical care. And at the time, there was a lot of trying to understand sort of what are the causes of this, and one of the things that stood out in large part, as reflected in Dr. Domit's work, that cardiometabolic morbidity is a major contributor to these disparities, and this can be for several reasons. One is due to the weight gain induced by the medications used to treat the psychiatric symptoms, particularly second generation antipsychotics. There are also health behaviors in terms of the types of food or the diet, and also excess smoking that can also contribute to excess morbidity and mortality. I also learned that there were differences in the quality of medical care or primary care in preventive care between patients with serious mental illness and general population, in large part reflecting that persons with serious serious mental illness often have special needs that are resulting from the symptoms that they experience, and really the best care would ideally be in coordination with with their primary care providers. And then also we can think about more recently medications like GLP-1s that target not only uh, uh, diabetes and obesity, and more recently people have been thinking about impulse control, but we can think about the slower uptake and slower usage of these medications in populations that face social disadvantages and fragmentation in care, such as persons with serious mental illness. And so you can think about persons with serious mental illness as a disparity population, as you know, and then also within that you can also consider other types of disparities within this population. So we could think about racial disparities. We know that racial and ethnic minorities often have worse morbidity and mortality, particularly in cardiovascular disease, which further can compound this notion of disparate outcomes. So we can think of disparities along the axes of serious mental illness versus general population. We can also think about racial disparities within this population. There are also ways to think about these two things together. In the talk, I'll really focus on racial disparities as a motivating example. And in general, in my work, I've thought about that in the general population, but for the purposes of this talk, you could think of it within the setting of persons with serious mental illness. One of the major challenges, as you know, with addressing disparities is that they arise in very complex ways. We can think about issues at the patient level. We can think about adherence. We can think about their ability to manage their own condition. And patients don't exist in a vacuum. We can think about issues related to familial and social support in the ways that people in their networks can help them overcome certain barriers, perhaps by providing transportation or reminding them of their medications, or helping them eat healthy meals, or encouraging them to change their behaviors. And also to deal with the psychological and psychosocial challenges that they face. And also they exist within, a healthcare setting. We can think about issues around the provider team and how knowledgeable they are of mental health and in the particular challenges. We can also think about their cultural competence. We can also think about policies that either encourage um, targeting cardiometabolic determinants of health that exist not only at the healthcare system level, but also at the local levels, state levels, and in national levels. Um, and so there are many places that we can intervene to craft interventions that address these disparities. The challenges is that we often face cost constraints, and it can also be difficult to implement and scale up interventions that are targeting so many determinants of health at the same time. And so one opportunity to make progress is to think about identifying the high leverage points that we can focus on as you know. And so causal decomposition analysis is really a way to think about identifying high leverage targets using observational data to help us prioritize points of intervention, and how we go about acting on those points of intervention can involve many different things. But the goal here is to really inform the development and adaptation and scaling up of interventions that address disparities. So given this goal of with an eye towards intervention, and particularly in the context of health disparities research, we have to address two things. One are notions of causal inference and notions of fairness. Traditionally, going back to the 1970s, when we think about the Oaxaca blinder decomposition, and also the advent of tools like regression analysis, those tools have often been used to sort of help us inform interventions. But there are two main things that we have to think about. One is causal inference, and we also have to think about fairness. So causal inference is important because these traditional factors, often when they have been of these traditional methods, when they've been used to uh, identify points of intervention, they often have done so without really taking into account this notion of confounding. So we may use these methods to identify factors that seem to explain the disparity or suggest that removing disparities in a particular factor might translate to the reduction of disparities in an outcome. But without addressing confounding, we can actually have the case that the potential impact on disparity might be attributable to some unmeasured factor, right? So it's some unmeasured factor that's really driving the issue, and without accounting for it, we're actually getting biased evidence, or perhaps may have overconfidence in the value of a particular factor as a point of intervention. So getting good causal inference is important. And so we want to use methods that allow us to build in notions of causal assumptions so that we can get robust evidence. But we also have to think about issues of fairness. And that's because when we think about differences, we have to when we think about differences, we're really thinking about ones that we would consider to be disparate or morally concerning. And that motivates everything that we do in disparities research. So it's not just that we see a difference between groups, it's that we see a difference in the outcome that we think is due to some unfair disadvantage that a population might face, and how that translates to disadvantage in the outcome. And so when we think about measuring disparity for this purpose, we want that disparity measure to pick up all the reasons why we might consider it to be more concerning. So, for example, if we thought that it's the background conditions, the socioeconomic conditions that people exist in that are driving disparate care and disparate health, we would want the disparity measure to really pick up differences due to those unfair reasons related to the conditions that a disadvantaged population faces. So, for example, if we were measuring disparity, we wouldn't want to measure disparity by comparing, say, different racial and ethnic groups among those who have the same level of socioeconomic status, because there would be one disparity among those who all share the same low socioeconomic status, and one disparity that would share the same high socioeconomic status. As an example, when I first started in public health, I was fortunate to work with Tom Leese, and we did a study in Southwest Baltimore where we saw persons who lived in the same socioeconomic environment, which was actually pretty disadvantaged, that there were actually very minimal disparities in hypertension and also many other outcomes. And so what that showed was that what's really was driving the disparity was the socioeconomic conditions. And also a corollary of that is when you're measuring disparities, you wouldn't want to do so by conditioning on those very socioeconomic conditions, because it would understate the disparity. So when we're measuring disparity, when we're thinking about measuring disparity, we want to do so in a way that captures the very mechanisms that we believe are contributing to differences that we think are morally concerning. So I want to just unpack that a little bit before launching into the framework for causal decomposition analysis. There are many ways of defining disparity. Paula Braveman and others have some very nice definitions, but in the context of this presentation, I think it's very relevant to use what's known as the Institute of Medicine definition. The Institute of Medicine has now been renamed the National Academies of Medicine, but in 2003, they put out a very influential report called Unequal Treatment. where they examined disparities in healthcare. And they had a very subtle definition there where they defined disparities in healthcare as those that were due to differences in the quality of healthcare that were not due to access-related factors or clinical needs or differences in preference for particular types of particular types of healthcare or the appropriateness of the intervention. And so what they really want to pick up are differences in healthcare that are apart from differences in these factors. Now, this definition has been debated quite a bit. It's been, debated that perhaps access-related factors, if you're really thinking about disparities in the broadest sense, if certain groups, due to their social disadvantage, have less access to healthcare, you really would want to include these as part of disparity and not discount them. Likewise, there are some arguments that perhaps preferences for treatment could reflect effects of social disadvantage due to perhaps lack of awareness about medical conditions, or perhaps stigma, or perhaps gaps in the relationship between social groups and healthcare systems due to historical missteps and mistrust that's arisen from that. And so maybe we do want to count preferences toward disparity. But it's often not debated that, we want disparities to reflect clinical appropriateness. And so if there are standing differences in clinical need, then if we're measuring disparities in clinical care, we wouldn't consider it disparate that there are different distributions of treatment across advantaged and disadvantaged groups because they have different levels of clinical need. And so this whole debate about, do we include certain factors or not, brings up this notion of what differences are allowable for measuring disparity, things that we might adjust away. Those might be clinical needs and other factors. And then what factors are sort of non-allowable? And these might be the differences due to the social conditions that people are in. And so when we measure disparity, we want to sort of adjust away the allowable factors. We adjust away the differences in clinical need, but do so in a way that doesn't over-adjust the differences in the non-allowable, in the differences in the non-allowable distributions. And so that would be sort of our measure of disparity. And one of the things that has falls out of this is, we can think about allowable covariates that sort of represent those differences in fair sources of the disparity, and the non-allowable covariates that represent unfair sources of the disparity. And there are different ways of thinking about what might be allowable versus non-allowable, as I alluded to before. So, for example, if we think about historically, oftentimes when you've seen the measurement of disparity, people have often adjusted for, say, factors related to genetic risk when thinking about disparities in cardiometabolic outcomes. And one of the arguments there rests on a notion of modifiability. The argument goes, well, these factors aren't modifiable by the person or by society, and so we shouldn't hold society account for these differences, and so we want to adjust away from them. That's one argument, or one ethical argument for treating pre-existing differences as things that shouldn't be used to contribute to disparity. And so you see this play out when people account for pre-existing conditions and say disparities in health outcomes, or you see this play out when measuring for factors related to, say, genetic risk. In the context of serious mental illness, a corollary could be, factors that are related to the risk of developing serious mental illness that also relate to downstream outcomes, right? A counter argument to that, a rebuttal which is also based on an ethical argument, is that, well, maybe we can't change these factors, but we can ameliorate their effects. So even if we can't necessarily change the fact that people have different genetic predispositions or different background risk factors like intergenerational wealth, or perhaps different pre-existing things, we can provide appropriate care, we can provide supports, etc. And so if we want to capture the full disparity, going about measuring disparity, we wouldn't want to treat so-called non-modifiable factors as allowable. We would actually want to treat them as non-allowable. And that's because we can hypothetically think about intervening to address their effects. So that's a counter argument. When we're thinking about measuring disparities in healthcare or any distributed good, such as medical treatment, what we're really thinking about is what would be a fair way of allocating that social good? What would be a fair way of allocating healthcare? What would be a fair way of allocating treatment? And so if we think about measuring disparities in treatment, what we're saying is conditional on those factors that we deem as a fair way of determining allocation, conditional on those factors, we would want to measure disparities in treatment. So, for example, if we're measuring disparities in receipt of GLP-1, we might condition on things that are in the clinical guidelines for allocating GLP-1 with under the assumption that our current clinical guidelines reflect morally appropriate ways of allocating that particular class of medications. And so why I'm going through all of these different reasons that there are different ways of thinking about allowability, and it's difficult, but they do rely on ethical arguments. However, even though this is challenging, it does allow us to facilitate communication and engagement with stakeholders. So if I present evidence about disparities, I can be very clear about what it is that I think is disparate, and perhaps find a way of finding common ground with people in the audience, in the stakeholders that may not know as much about why these disparities exist. And so when I'm presenting notions of difference and different outcomes, we can say, well, what I'm really getting at is this morally concerning, and here's why I think it's morally concerning. And of course that's open to debate, but that's a really good thing, and it also makes the analysis transparent and in some sense encourages scientific dialogue. So these non-allowable covariates are, again, as I alluded to before, things that are implicated in disparity. In the context of disparity in health outcomes or healthcare outcomes, these might involve things like the ability to pay for healthcare, poor patient-provider interaction due to poor cultural competence or areas in communication, a lack of patient knowledge and awareness and ability to manage their condition, et cetera. All of these things could reflect difficulties due to the social conditions that disadvantaged groups find themselves in. And so again, as I was alluding to before, what we want to do is we want to think about how do we reduce disparities in an outcome? And we want to think about how do we identify potential targets of intervention to reduce that disparity. So that means we have two tasks that we have to do is we have to think about what's the disparity in the outcome. And so for that, we have to think about what are outcome allowable variables that we might adjust for there. And then once I have that measure of disparity, I want to think about, okay, how can I change that? And so then I have to think about removing disparities in a determinant of the outcome. And so for that, I have to think about, okay, what's a disparity in the determinant? Think about what are allowable variables for that. And so that's my hypothetical question that I'm interested in. And then I want to try to emulate that using observational data. And what I'll allude to here, and I'll reinforce later, is that in the emulation of that scientific question, I can use non-allowable covariates to emulate that hypothetical. And I can do so in a way that doesn't over-adjust the disparity, right? So I can study the disparities that I want to, that would only be defined in terms of morally appropriate sort of covariates. But I can use these other covariates like that reflect socioeconomic conditions or social conditions that are giving rise to the disparity. I can use those covariates to help with the estimation to do good causal inference. And that's really the contribution of causal decomposition analysis, is that allow us to study an arguably morally relevant measure of difference, which we say is disparity, but do so in a way that gets us good causal inference. So in order to ground this a little bit, I'm going to use an example to sort of ground this scientific question. So the example that I'm working from here is in this talk is going to look at racial disparities in hypertension control. And suppose for measuring racial disparities in hypertension control, which would be our outcome, we might want to standardize for demographics. And we might want to do that. We might want to treat demographics such as age and sex as allowable, because in many clinical settings, you have the fact that the Black population is younger and often has a higher proportion of women than, say, the white population. And these are both predictors of good hypertension control. And so if you don't balance on these factors, you can actually understate the level of difference because of the statistical advantage that those groups have on these factors. So we're starting with the disparity measure where we're balancing by age and sex. We're treating those as allowable. And then we're asking how that disparity would change if we could equalize rates in a determinant of the outcome. And so for here, we're thinking about treatment intensification as a point of intervention. So why are we choosing treatment intensification as a point of intervention? One reason is because there's this notion of clinical inertia. And that can arise because patients may have different providers, and there may be different providers providing different medicines. You have fragmentation of care. If a patient walks in with uncontrolled blood pressure, there could be a delay, either because maybe that provider is not the one who prescribed that medication, or there could be a delay because there's lack of communication between the providers. There could be a delay because they want to wait and see how things resolve. But there's this notion of clinical inertia, and if the level of clinical inertia is differential across racial groups, perhaps due to gaps in the patient-provider relationship or the quality of care that they receive, these can impact outcomes. So when we think about equalizing treatment intensification, do we want to equalize marginally? Probably not, because the Black and white populations will often in clinical samples have different distributions of clinical indication. So, for example, if you look within an EMR data set, you may see that the Black population may have a higher average systolic blood pressure at baseline. They may have more or higher prevalence of comorbidities. And so if we were to equalize treatment intensification marginally, it would mean that we're thinking about an intervention that doesn't respect the clinical needs of the Black population. So what we really want to do is we would try to equalize actually within levels of clinical needs and factors that are at least as dictated by clinical guidelines appropriate for determining when to intensify treatment. So we're thinking about one, a disparity where we're defining that disparity by outcome allowable covariates, age, and sex. And then we're thinking about a disparity that we want to remove in the disparity in treatment intensification that's defined by age and sex, and also measures of clinical need. So let's unpack that. So this represents our observed outcome process for, say, the Black population, where um, uh, they are intensified at a certain rate, and that leads to a distribution of hypertension control. And then we have an observed process generating the outcome, again, where the white population is intensified at a certain rate, and it leads to a distribution of hypertension control. And we hypothesize, or we may see in the data, that actually the rate of intensification, given their clinical need, is actually lower among the Black population than among the white population. And we also may see that, given say demographics, that the rate of uncontrolled hypertension is higher among the Black population than it is in the white population. So contrasting these two distributions, and the outcome leads us to our measure of the observed disparity. Now, when we're thinking about how can we intervene to change this disparity, right? We want to quantify the impact of removing the disparity in treatment intensification. So to do that, we introduce something hypothetical, a counterfactual scenario. So to do that, we can imagine what the distribution of hypertension control would be under the Black population if we altered their distribution of treatment intensification. And for this presentation and in causal decomposition, we often do perhaps the simplest thing to think about: what if we just set the rate of treatment intensification of the Black population to what it is in the white population, conditional on measures of clinical need, conditional on the intervention allowable convenience. So that under that hypothetical scenario, that's going to lead to a counterfactual distribution of hypertension control in the Black population. And so if we compared the counterfactual distribution in the Black population to the mean, and compare that to the observed distribution of hypertension control in the population, and took the mean and took the difference between these two means, that would give us how much disparity would remain in hypertension control after removing disparities in treatment intensification in a fair way, i.e., ways that account for clinical need. And so if we contrast the residual disparity, how much would remain, versus the observed disparity, we get a quantity known as the reduced disparity, which is equivalent to just comparing the observed distribution of hypertension control in the Black population to the counterfactual distribution of hypertension control among the Black population. So to go back to our key points, we're really interested in how racial disparities in hypertension control, standardizing for demographics, how they would change upon equalizing treatment intensification rates within levels of demographics and clinical factors. So the key points here is that we're only using outcome allowables or demographics to define the disparity in our outcome. Whereas when we think about, equalizing the disparity in treatment intensification, we're thinking about only using demographics and clinical factors to define how that equalization occurs. So we're equalizing within levels of demographics and clinical factors. These are called intervention allowable variables. But what we're not doing is we're not defining the disparity in hypertension control according to socioeconomic status, which is a non-allowable variable for reasons that I discussed earlier, because we don't want to over-adjust the measure of disparity. And we're also not considering an intervention that equalizes treatment intensification or punitive intervention within levels of socioeconomic status, because if we were to do so, we would be equalizing the disparity, or we were removing the disparity differently for persons with low versus high socioeconomic status. And as I alluded to before, when thinking about the place not race study earlier, those disparities are actually going to be smaller when you condition on socioeconomic status, because people with who are matched on, say, poor socioeconomic conditions are going to have more similar distributions of, 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 of treatment intensification, and those with high socioeconomic status are going to have similar distributions. And so if we were to equalize within levels of socioeconomic status, that would actually be, number one, an unfair intervention that wouldn't reflect what we ideally want to do in medical care, is to provide care independent of socioeconomic status. And so we're not using socioeconomic status to define the outcome disparity or how we equalize treatment intensification. And so just to recap, we're going to start with an appropriate measure of disparity for our outcome, hypertension control, and that's going to do so by balancing on demographics, age, and sex. And then we're going to think about a fair way of equalizing the point of intervention, which is treatment intensification, where that equalization is going to be done within levels of clinical need or factors that represent clinical appropriateness. And those factors will be perhaps things that reflect clinical indications. And the special sauce of causal decomposition analysis is that during the estimation process, we can use additional variables, such as non-allowables, to account for potential biases, such as confounding. But they're not going to, the analysis is going to do so in a way that doesn't redefine our outcome disparity and doesn't redefine how we equalize. As a side note, there are other ways of thinking of posing counterfactuals here. One is causal mediation analysis. One limitation of this approach is that it would over-adjust the disparity measure because it implicitly would adjust the disparity measure for non-allowable factors such as socioeconomic status. And it would also employ an unfair equalization by, again, doing the equalization within levels of socioeconomic status, which, again, as I said, is problematic. So to recap here, we have an observed outcome distribution for the Black population. We want to know what is the counterfactual outcome distribution if we could remove the disparity in treatment intensification. And then we want to contrast those two because this quantity here would tell us how the disparity would change, how the disparity in hypertension control would change if we could remove the disparity in a determinant of hypertension control, vis-a-vis if we could remove the disparity in treatment intensification. Now, this is essentially a hypothetical scenario. This is a formalization of what you'll see later, but when we think about measuring outcome disparities, you can think of that as just standardizing the outcome disparities by the outcome allowable covariates. So for example, by age and sex, that's what's represented in this top line. So this top line will tell us what's the standardized mean for the Black population after standardizing for age and sex. And then we want to also standardize the counterfactual mean. And that's what's represented by this bottom line. And so I have some notation here. You don't have to pay attention to it, but for those who are tracking, G is our social group. 1 is the disadvantaged population. 0 is the advantaged population. Y is our outcome hypertension control. Z is our point of intervention. When you see AY, it's talking about our outcome allowable covariates, such as age. And implicitly, when we think about standardizing these outcome allowable covariates to measure our observed outcomes, we have to choose a distribution to standardize to. So, and that distribution can come from a standard population that's denoted by T. Typically, I use a within study standard population, so some subgroup within the study population. And then when you see AZ, it's talking about intervention allowable covariates. These are variables that define how we equalize treatment intensification. So this might be blood pressure at baseline, comorbidities at baseline, etc. And implicit here, I'm talking about counterfactual outcomes or potential outcomes that would arise under a hypothetical intervention to shift the distribution of treatment intensification. And again, we're shifting the distribution of treatment intensification conditional on factors related to clinical need, and that might represent factors such as baseline blood pressure and age and sex. And so we have these assumptions here. We have assumptions here precisely because what we observe in the data is an outcome process that's unfolded before our eyes. We see that there's a distribution of hypertension control that reflects a certain distribution of observed treatment intensification. And what we want to do in order to identify whether removing the disparities in treatment intensification would lead to a reduction in the disparity in hypertension control, we want to pose a counterfactual, where we've removed the disparity in treatment intensification. Then we ask what would be the outcome distribution for the Black population in this scenario. This is a counterfactual. It's not something that we see with our eyes. We don't have any data on this scenario. What we do have is we have data on this observed process where there is a disparity in treatment intensification. And so what we want to do is we want to somehow use this observed data and use it in such a way that we try to emulate this hypothetical scenario where we don't have data. And so we need a bridge from the observed data to this counterfactual where we don't have data. And that's what the assumptions allow us to do. And so there's a number of assumptions. The first set of assumptions deal with just measuring disparity, and the second set of assumptions deal with good causal inference. So things like unconfoundedness, things like having a well-specified notion of the intervention, things like being able to observe the appropriate values of what we're intervening on. So the first part, which deals with defining disparities or measuring disparities, really deals with two forms of overlap in the distributions of allowable covariates. And the first assumption is really that we have overlap in the distribution of outcome allowables. So this would be, for example, you have overlap in the distributions of demographic covariates. And that's basically there because we want to balance the distribution of age and sex when we're measuring the disparity in hypertension control. And so in order to do that, in order to check that assumption, we might perhaps look within the standard population, look at its distribution of, say, age, and for those values, ensure that those values are represented in both social groups, say among Black and white populations. The key point here is that this allows us to actually balance the age and sex distributions so that we can measure disparity in hypertension control. So we could check that by just, again, looking. Well, first, we have to choose what the standard population would be. Often we can choose the disadvantaged group as the standard population. We can talk about that in the discussion. But if we were to do so, we would note its age range and then just ensure that in the white population, that distribution was contained within the age range of the white population. And if that were so, we could balance the distributions of age and sex to measure outcome disparities. The second form of overlap is that we want to balance. Let me say we want to. It's a bit of a typo there. We actually don't want to balance the distributions of the intervention allowable covariates, but we want there to be enough overlap that it makes sense to equalize treatment intensification in an appropriate way. And what do I mean by that is, like, if you had complete separation in baseline blood pressure, such that you had maybe the Black group had blood pressures all above 160 and the white population had blood pressure was between 140 and 150, it wouldn't make sense to talk about an equalization for those who have the same level of blood pressures, because you wouldn't be able to find any set of Black and white persons who have the same blood pressures. So we have to have overlap in the blood pressure, baseline blood pressure distribution to talk about equalizing treatment intensification rates within levels of blood pressure. So that's what this assumption really gets at. So we just really would want to see overlap in that distribution so that it was feasible or sensible to talk about an intervention that equalizes treatment intensification fairly. And then we get to the causal assumptions, such as unconfoundedness, which many of you are aware of. And really here, we want to measure the factors that confound the effect of the point of interventions on the outcome. So we want to think about the effect of treatment intensification on the outcome. We want to think about the treatment assignment mechanism. What are all the factors, fair and unfair, that are determining how treatment that determine decisions to intensify treatment. And we want to be able to control for those, especially if they're related to the outcome. It turns out that oftentimes this is going to include clinical indications, but for many reasons, as I alluded to before, there can be other unfair reasons why people are being intensified versus not, that might reflect differences in the implicit bias within the clinical provider relationship with the patient. It may reflect differences in suspected adherence, et cetera. And so in the estimation process, we have to account not only for these allowable covariates, but we also have to account for these non-allowable covariates. And just to give you an example here, Z is our treatment intensification. We're interested in its effect on the outcome, but structurally, we know that perhaps treatment intensification may differ for older and younger persons. There may be implicit biases between, say, men and women, or perhaps due to factors. There may be implicit biases according to perhaps the actual social group. So maybe persons who belong to the Black population may be suspected of having poor adherence, or maybe perhaps due to gaps in the patient-provider relationship. They may be relying on stereotypes about that population. It's a phenomenon known as statistical discrimination. That could also be a contributing factor to treatment intensification. There also may be factors related to social conditions that also impact treatment decision making. And then there also may be clinical indications or reasons why people may be intensified versus not. So maybe their blood pressure is controlled, and so maybe they're not intensified. Or maybe it's uncontrolled, and so maybe they are intensified. And so in order to isolate the effect of treatment intensification on the outcome, we have to control for all of its causes that are related to the outcome. So that would mean adjusting for not just outcome allowable covariates such as demographics, and intervention allowable covariates such as clinical factors, but also non-allowable factors such as socioeconomic status or measures related to social conditions. And implicitly, we're already adjusting for the groups. And so conditional on all these factors, we assume that we have all the relevant confounders measured and are able to adjust for them somehow in the analysis. And then again, we have that we want to really emulate a fair equalization. What that really means is that we're able to observe the relevant values of treatment intensification implied by the distribution of Z that we want to emulate. So whatever the fair distribution would be, that we're saying is perhaps exists among the white population, given their clinical needs, that we would see that level of variation among the Black population. The reason why we want that is so that we can emulate that fair distribution among Black population. And so basically what we would want to do is look within, say, the white population, note the relevant values given the factors that indicate clinical needs, and just see that those values are represented among the Black population. So one consequence of this is that you can actually allow for deterministic relationships. So if among the white population there are ranges of blood pressure where no one would ever be intensified, that's okay as long as there are such persons who are not intensified when they have that same level of blood pressure, of baseline blood pressure. And then finally, we have this notion of intervention consistency. And this is the final link from the hypothetical to the observed data, is that we can infer potential outcomes from observed outcomes when the observed level of treatment intensification matches the hypothetical. And this really follows from two things. One is that we have an idea of what it means to intensify a person's treatment. So it's reasonable to expect that potential outcome to match what would happen under intervention. And then two, and the second thing can be relaxed, is that intensifying treatment for one person wouldn't affect the hypertension control of another person. And in this setting, we don't have resource constraints on antihypertensive medications. And so we expect that this assumption might hold. And just, to sort of say what's going on here is we're basically saying that the outcomes under a hypothetical study where we could intervene to change to change treatment intensification. If we looked at hypertension control, say for a person who's intensified under our hypothetical, for that same person, we could use their observed outcome if in fact they were actually intensified. And so if we would expect the same outcomes under the same type of treatment, whether that treatment arose either naturally in the real world versus in the hypothetical study, lets us use the observed outcomes to infer what the potential outcomes would be. And so together, those three assumptions allow us to make the leap from the observed data to the counterfactual that we don't have data on. And so if those assumptions hold, we can start to talk about estimation. So how do we do that? The big picture here, again, is we want to estimate these observed disparities to start with. And then we want to think about how that disparity will change if we could entertain this counterfactual, remove disparities in a determinant, vis-a-vis treatment intensification. So we need to be able to estimate standardized means for each group. So for the Black population and the white population, after standardizing from demographics like age and sex. And then we want to estimate the standardized counterfactual means standardized for age and sex. So the observed means, I'm calling theta G, where theta 1 refers to the standardized mean for the Black population, theta 0 is the standardized mean for the white population, and theta 1 star is the counterfactual mean for the Black population under the hypothetical scenario. If I put these together, I can calculate the observed disparity, balancing on the demographics. I can calculate how that disparity will change by contrasting the counterfactual mean for the Black population versus the observed mean for the Black population, again, standardizing for age and sex. And then I can see what the disparity would be under that intervention by contrasting the observed mean for the the counterfactual mean for the Black population versus the observed mean for the white population. And so you can think of if we take the observed disparity, add on the effect of disparity, that will give us the residual disparity. Another way an equivalent way to think about this could be to start with the observed disparity and think of it as the sum of how much will be reduced versus how much would remain. And the amount that would remain is the residual disparity. So our first task is to estimate the group-specific means, because these are what allow us to start with the observed disparity. And these estimators are really isomorphic or analogous to the estimators that we use for average treatment effect estimators in causal inference. With the big difference here being that we're not trying to balance on confounders of a social group membership. We're just really trying to balance on outcome allowable factors. And so there are three options here. One is to model social group membership and to model membership in the standard population that we've chosen. And there we're modeling how the groups differ in terms of their distribution of allowable covariates. So how do outcome allowable covariates relate to membership in groups? Another way to go about this is to do model-based standardization. And so instead of modeling membership in certain groups, we model the outcome process as a function of the outcome of outcomes. So we would be regressing the outcome on, say, age, and there we can just do model-based standardization. Model-based standardization. And then there are doubly robust ways that combine these two approaches that give you the right answer if you either get the weights right or if you get the outcome model right. And so for there, I'm just going to show you the weighting approach. There, we would start by, again, as I indicated, regressing social group on, say, the outcome allowable covariance. So say we regress it on, say, age and sex. Here I'm just showing age for space reasons. We could do that using a logistic regression. And then we would also want to model the membership in the standard population on, say, age and sex. And then getting predicted values of membership in those populations from these models. So we get a predicted value belonging to a particular race given the outcome allowables. That would be our first set of predicted values for each person from the first model. Then a second set of predicted values for membership in the standard population from the second model. We can create inverse probability weights where the weight is just the ratio of I have these reversed and I apologize. This should be membership in the Black population in the denominator, given age, and membership in the standard population, given age, in the numerator, which is what is reflected here on the left-hand side. And then here is just a constant scaling the proportion of people who belong in the Black population versus the standard population. And that's that would be the weight for the Black group. And in the white population, again, this notion is reversed, but here we would have the estimated probability of belonging to the white population given age, and then with the numerator as the probability belonging to the white to the standard population given the outcome allowables. And then here would be just a constant factor that's actually the inverse of this. And so those two weights, if we took the weighted average among the Black population using their weights and then the weighted average of the white population using that group and took the difference, that would estimate the standardized weight difference. So this would be a weighting approach to use to estimate the observed disparity. And as I alluded to earlier, we have a working paper where we've mapped out how to estimate that counterfactual mean for the Black population. And it turns out there are actually many ways of going about it. There's a simple linear estimator that's really simple and intuitive and actually extends the Oaxaca blinder decompositions from economics. But it has very strict assumptions. There's a class of flexible estimators that don't have such stringent parametric assumptions. And these estimators model the distribution of treatment intensification. So you would need to model the density or the probability of being intensified given a set of covariates, which is fine if you're thinking about a binary point of intervention like treatment intensification. But if it's continuous, say we were thinking about the dose, or say we were thinking about perhaps some other continuous determinant, it can actually be really difficult to model a continuous distribution that's conditional on covariance. So that motivates a new class of estimators that we have in our working paper. And that's where you avoid modeling the distributions by using cleverly constructed bridge samples that you construct by sampling either the point of intervention or sampling the non-allowable covariance. And what's nice about these estimators, even though they're less intuitive, they can handle pretty much any type of point of intervention, um, whether it's continuous or categorical, binary, et cetera, or if you have multiple ones. And so you can do so without this this really tough modeling challenge that you would face with the other types of estimators. And so these are new, they're in our working paper. And that's referenced at the beginning of the talk and also the slides. And I'm going to just present to you the really simple weighting estimator for where you model the distribution of the point of intervention, treatment intensification, because in this case, it's categorical or binary. One thing I neglected to mention is that in this working paper, whether you use the approach that models distributions or the approach that doesn't, you again can have a class of weighting estimators or ones that model the outcome process. And then there's also classes of estimators that combine these two approaches in a very robust way that you still get the right answer if you get either the weights right or the models for the outcome process right, or any combination of the pieces in the estimators. But again, what I'm just going to show you is the very simple weighting approach where you model the distribution of treatment intensification. So here you would want to regress treatment intensification on the outcome allowables, and you're going to do that among, say, the white population, because this represents the distribution that would allow us, if we could emulate it in the Black population, would remove the disparity in a fair way, would remove the disparity in treatment intensification in a fair way. So we could estimate this by fitting a logistic regression model conditional on outcome allowable covariance. So perhaps outcome allowable covariance and intervention allowable covariance, so say age and sex, and also baseline blood pressure. And we would fit this model among the white population, get predicted values, use those predicted values as our numerator in the weight. In the denominator, we fit a similar model, but this time it's fit among the Black population. It's fit among the Black population because we're trying to estimate the observed distribution of treatment intensification. And because we're estimating the observed distribution of treatment intensification, we also want to account for the fact that it depends on socioeconomic status. And so we would include that as well as a covariate in addition to the intervention and outcome allowable covariates. And so we would take the predicted values from this model, and that would be our denominator. And so our denominator, again, is the observed distribution of treatment intensification. The numerator is the distribution of treatment intensification that we want to emulate that only depends on intervention and outcome allowable covariance. And so the weight that we have here shifts the observed distribution of treatment intensification among the Black population, which depends on socioeconomic status and is different than the white population. We want to shift that distribution to the distribution of treatment intensification in the white population, but only conditional on the allowable covariance. And so in this hypothetical Black population, treatment intensification no longer depends on socioeconomic status once we condition on the allowable covariance. And so if we took a weighted average of the Black population using this weight, where this weight is also multiplied times the weights I just described in the previous slides, for that would allow us to estimate this counterfactual. So we have some examples before I wrap up. Two of them.
Actually, John, can I jump in with one quick question that just came in?
Yeah.
A question came in. It's probably for the slide. What is W1 on slide 46?
Oh, W1 is this weight here that was used to estimate the observed disparity. And again, this here is actually in reverse, and I really apologize for that. So this should be flipped, and this should be flipped. You can think of the W1 sets up the standardization of the outcome across age and sex. So it's setting up the measure of disparity. So that's what W1 does. And when we use it to estimate the outcome disparities, that's why we're only weighting by W1 here. when we use it in the counterfactual scenario, we not only have to standardize for age and sex across race, we also have to emulate the shift in the distribution of the point of intervention. And so that's why it's multiplied by this second weight Q that actually accomplishes the shift in the distribution. So W1 allows us to standardize the potential outcomes emulated across age and sex so that we have an appropriate measure of disparity. And W1 star allows us to shift the distribution of treatment intensification within the Black population. And implicitly, you can think for the white population, this W1 star is implicitly in 1. And so it would be just W0, which is the standardization for the population. Did that answer your question? Okay.
Yes, I assume so. Thank you.
Okay, great. No problem. That was a great question. And it's actually encouraging because it means that it sounds like you're tracking. So just as some quick examples, we looked at treatment intensification, and I'm so eternally grateful for my collaborators, Tony Bunyasai, Raquel Greer, and Yejin Su, who we did a lot of work to actually measure treatment intensification within the GHCP health system. And so we set up an analysis where we're looking at the visit level. I can talk more about that later. We did this across all of GHCP, so there's about 30 clinics representing about 25,000 patients with uncontrolled hypertension. Where the start of follow-up we were thinking about is at a point of primary care. We wanted to know if we remove disparities in treatment intensification within the following 14 days, would that reduce disparities in uncontrolled hypertension measured 6 months later? And so for there, we measure treatment intensification as either initiating an antihypertensive medication if they weren't on it, changing or actually increasing the antihypertensive dose, or adding a new class of antihypertensive, which maps to the construct of treatment intensification. For outcome allowable covariates, we used age and sex for reasons as I described earlier. For the intervention allowable covariates, we used blood pressure, measures of medication history, and measures of medical history. These were all measured at the point of the visit or before. And these were really factors that were drawn from the American Heart Association clinical guidelines or the American cardiology guidelines. And for non-allowables, we used linked measures of block group level area deprivation, defined at the national level, the ranking. We also considered measures of healthcare access, such as health insurance, and also healthcare engagement, such as the number of prior healthcare visits. And what we found was that there was a small disparity in treatment intensification, about a difference of 1.9%, with Blacks receiving less intensification once you accounted for measures of clinical appropriateness. We found once you accounted for measures once you accounted for age and sex, we found a disparity of 5.5%, with Blacks having more uncontrolled hypertension than whites. And we found that hypothetical intervention to equalize treatment intensification would actually not move the disparity much at all. And that's possibly because the disparity in treatment intensification is small. So we looked at another point of intervention, medication adherence, and I'm eternally grateful to Lisa Cooper, the director of the Center for Health Equity, and also Jim Marsteller, the co-PIs on what was known as the Rich Life trial, which was the pragmatic trial. And there we did something really special. Is we thought about using the control arm of this trial, where there was minimal interventions to the healthcare process. There were some interventions, but they were arguably minimal. And so we used the control arm. It's a much smaller data set, so it's 750 patients or so with uncontrolled hypertension. And then for there, our point of intervention was adherence, which was measured using the Mariski scale, which taps into reasons why they forgot. So there was four items. We looked at age and sex as outcome allowables. For intervention allowables, this is a health behavior, not a distributed good. And so we wanted to equalize marginally because we thought everyone should have ideal adherence. And so we couldn't think of what a reason why we would want to equalize conditional on certain factors. So we did not have any intervention allowable covariates. And then the strength of using this smaller data set was that we had a rich set of non-allowable covariates, tapping into measures of social demographics, measures of patient activation, measures of stress and support, and also measures of baseline health. And again, the strength of this is that there's a much richer set of adjustment covariates that just aren't often available in EMRs, that these were collected by a survey within the study. And so looking at our results, we found that after adjusting, well, actually not adjusting for anything, we saw a difference in the distribution of adherence, with the Black population consistently having non-adherence over time at a much higher rate than the white population. And we found that after adjusting for age and sex and the outcome disparity, we found that Blacks had a rate of uncontrolled hypertension that was 9.8 percentage points higher. And then if you were to equalize the distribution of treatment intensification, we found that that disparity would be reduced from 9.8 to 3.8. However, this is a very imprecise measure because we have a smaller sample size. And so going back and thinking about, our goal is to inform new and effective interventions, or to adapt existing interventions. What our results suggest that perhaps an intervention to reduce hypertension control disparities in this population would focus more on issues surrounding non-adherence rather than issues surrounding treatment intensification. And again, we could target issues around adherence in ways that relate to the individual patient. So maybe perhaps their knowledge and awareness of their condition, but we can also think about contextual factors. So maybe there are issues with pharmacy availability, and we might think about mailing, or perhaps providing or policies that might support pharmacies remaining open in disadvantaged communities. So even though we're identifying things at the individual level, there may be ways that we can target those factors at both the individual level, but also at higher levels, thinking about the ecology of how this happens. So just to wrap up, allowability is important to consider. It's value laden. We can estimate disparity that really respects allowability, and we can do so using non-allowable variables to meet causal assumptions, but do so in a way that doesn't change our notion of disparity and change our notion of a fair intervention. This has practical considerations in that we would want to, we definitely want to think about what are these allowable variables, try to measure them in our data, and we can have debates about what those factors should be. When we think about treatments, guidelines are often helpful. And again, we have our causal assumptions that should also influence our study design. And both of these encourage transparency there. So we can use these tools to address disparities. And the hope is that we can use these tools to address disparities in mental health, and perhaps also the premature mortality and excess morbidity. Just some further reading for you, and I'd like to thank you guys for your time. And Liz, sorry that I ran a little more over.
That's great. Thank you so much. This is a great introduction to a complex area. So I appreciate your careful thought about it all, and us learning a lot. I also want to be clear, the question, as you labeled it, the good question I asked was not my own question, so someone else gets credit for that.
Sure,
They
sure,
put it
sure.
in the Q&A. So we don't have any questions in the Q&A, so I will just ask a question myself, and then hopefully that will prompt others. And I think people can also, if you're comfortable to be in the recording, folks can also raise their hand and ask a question that way. We have just under 10 minutes for discussion. So this is all really interesting, and I think one question I have many questions, but one I'd love to hear a little more about is if you have any thoughts on how people sort of think about defining what is an allowable versus a non-allowable covariate, and sort of any processes used for that, or just kind of, I'd love to hear a little more.
Yeah. So we have some, I will give a plug. So we have a working paper with Khadija Ferryman, who's a bioethicist, and Emmanuel Drabo, who's an economist. And so there we're thinking about, particularly for allowability with respect to treatments, we're thinking about um, one way to say it in a simple sense is like if we made decisions based on these factors, how would that impact the distributions and downstream outcomes? So you can map that out at individual levels or expected outcomes, et cetera, but it really is a formal framework for thinking about resource allocation that I believe people actually use in practice. That's in that's a work that we have in process. Hopefully we'll have it posted later this year. Um, with respect to outcomes, generally I'm pretty hesitant to deem things as allowable. But one thing that I do often is think about factors that might mask disparity. So if the disadvantaged group is advantaged for whatever reason on a particular factor, if you don't account for that, if you don't adjust for that, you might actually mask disparity due to other processes, just in terms of how they balance out. So I think about, what should be appropriate ways of guiding treatment, which might think about ways that are get to fair allocation, which hopefully our future paper will help lay out. And then in this context, to think about what factors might mask disparity when I'm thinking about health outcomes. So I think about things differently if I'm thinking about whether the disparity in question is an allocated good versus whether it's a health status.
Thanks, that's really helpful. And yeah, that paper sounds useful. Maybe then another question sort of for the Alacrity crowd. Do you know if there's been much, you referenced at the beginning, there's clearly some relevance for people with serious mental illness and sort of thinking about disadvantage with and health conditions, et cetera. Do you know if there are many examples of using these frameworks in sort of mental health and mental health services and serious mental illness and these sorts of areas, or is it fairly,
It's wide open. It's something I wanted to do when I started this work, but just for various reasons, I've decided to work in other areas. But I would love to, engage with this substantive area with these methods and also even broader perspectives. Think about target trial emulations and stuff like that. It's always been an interest of mine.
Yeah, it's interesting, and I wonder, it could be an interesting conversation around like what data would be required, and I wonder if that's part of one of the challenges is sort of whether we'd have the variables that we would really ideally.
Yeah, at least like 10 years ago, I just decided to move in areas where there was richer data, but I think maybe there are ways of alluding to what we did with Lisa Cooper and Jill Marsteller's data, leveraging data from trials with control arms is an opportunity because there may be richer data there. The issue there is sample size and also generalizability, but those are separate conversations.
Great. Well, we do have one question that came in from the audience, and then we'll probably wrap up. So I'll just read it. Can you provide examples of continuous disparities? So I guess I'm not, then it says even age continuous sounds strange as continuous. So I'm not totally sure, but I guess it's sort of maybe the idea is like, instead of say different groups, are there ways to define disparities more on a continuous spectrum?
Yeah, there are. Those are definitely more complex. And there you're thinking about some curve, perhaps. So you would have the outcome there, and you would have some curve that was somehow either reweighted to account for uh, different differential distributions. Oftentimes, those measures of inequality are unadjusted for that reason. Um, and then there are also ways of thinking of like, what's the notion of a disparate, uh, sort of a disparate distribution. So there are methods out there for that, and in the future, I'm planning to work on those things. But um, and you can think of counterfactual scenarios, but they often don't account for outcome modeling.
Yeah.
So, for example, if we were thinking about disparities and not just the mean of blood pressure, but the distribution of blood pressure, that would be something. And economists have
Yeah, even more complex. So this has been great, good food for thought, and I think also hopefully inspired some folks to learn more and potentially use these methods and ideas in their own work. Construction is getting louder behind me, so thank you all for joining us. It was really great to have you. Thank you so much, John, for teaching us all and helping us learn. And we look forward to seeing you all at future webinars. We don't have any more on the books right now, but we welcome suggestions for topics, and we look forward to engaging with you in lots of different ways. So thanks so much.
Thank you.